University Hospitals of Cleveland, where he is now professor of pathology and neurology, as well as co-director of the National Prion Disease Pathology Surveillance Center. I will now turn it over to Dr. Cohen.
Okay, this will stop up the screen, guys. Let's share our screen. And yeah, you can see my thing. Okay, great. So everybody can see the PowerPoint. Sorry for the delay. I'll try and get us done on time. I don't know. I'm gonna have to crank it up to 1.25, I think. So we'll try and do that speed. So this is it's quite an honor for me to do this. I don't get a chance to talk to fellows much at all because we don't have a fellowship program. And so Angelica has guided me towards a curriculum that I hope will be useful. But again, if you're not a fellow, we'll count you as a friend. So here are the disclosures. I don't have any current disclosures. I actually have one. I have one, which is that the flyer said I'm director of the division of neuropathology. We don't have a division. I'm not as director. But my other disclosures is I don't have any. But if you want to send me some money, I'd be happy to write whatever you want where the red stuff is here. So now, here are the learning objectives. And once again, Angelica helped a lot. And the idea was that we're trying to do stuff which is useful for fellows. We said the research stuff belongs in meetings, and this is not that. This is a more informal teaching round. So we're going to cover three main aspects. The first, we're going to talk about the pre-mortem, or just basically the clinical diagnosis, to the extent that we can do that. We can help our clinicians do that, because they really, as you have experience from time to time, they can sometimes be sort of clueless, when it comes to things. And particularly, and one wouldn't think this would be the case, but particularly the problem of base rate neglect, the idea that rare diseases are rare, somehow doesn't seem to sink in, maybe as a result of prionophobia that seems to be more prevalent than prion disease. And so we're going to talk about how we can help our clinical colleagues do the right thing. That'll be the first part, short part. And then, of course, we'll get into the, the fun stuff, the neuropathology part of prion disease. And we're going to talk about some common stuff, some less common stuff, and some really uncommon stuff, just so we have familiarity with the spectrum of prion disease, so we can better approach, situations should it arise. And finally, again, a couple of slides about risks and safety and how to find information, if you think you have a problem with prions. So how are we going to do it? Like I said, really three parts. We're going to figure out, again, our job is to help our clinical colleagues to do no harm. And again, giving somebody a diagnosis of an untreatable terminal disease, is not beneficial, particularly if it's wrong. Then we're going to talk about histopathology. We're going to look at common, uncommon, and very unusual case, just to get the spectrum under our scopes. And then finally, what happens when something happens? We get a panic call from the lab. Well, we just ran this CSF and, patient has Prion disease or what have you, and now they're going to void the warranty on our machines and all this ridiculous stuff that we hear. So this is the first thing. This is a case I got out a couple of weeks ago, just when I was asked to do this. And so here you have the clinical history. I guess CJF is supposed to be CJD. I just got this right off the chart. And so what you see is the impression is that, there's this signal stuff and, could be this, could be that, but, could be. And as soon as clinicians see Jakob-Creutzfeldt disease, Creutzfeldt-Jakob disease, that's the diagnosis they go with. So, of course, they send a case here, at autopsy. And here we have it. So once again, base rate neglect. And as you see, once you're familiar, as most of the neuropathology community is with the rarity of prion disease, then you recognize, of course, that most of the time, the diagnosis of prion disease is going to be wrong, because it's just a rare disease. And so this is a section of that case that was sent here with that, diagnosis. And I don't know if you recognize the guy down here. It's kind of a local hero down here in the lower right-hand corner. That's Potter Stewart. And again, most of you are probably too young, but just under 60 years ago, just under about a mile from where I'm sitting, there was a case that reached the Supreme Court, Jacobellis versus Ohio, having to do with the viewing of hardcore pornography. And of course, there's the famous saying everybody knows, which is, I may not be able to define what's meant by hardcore pornography, but I know it when I see it. What many people don't remember is the rest of the phrase, which is to say, and this is not that. And that's in fact what's going on here. So what do you see? Well, of course you see this vacuolization, but you'll also see these neurons with the shrunken dark nucleus and the eosinophilic cytoplasm. So of course, even though it said, no history of an oxic brain injury, it's an oxic brain injury, right? So this is what we have to know. So is there anything we can do up front, to help our clinicians to, again, not make mistakes? And there is, and I don't know if you guys know about this or not, and that's part of the reason for these teaching rounds, but this is our man in Milan is Alberto Bizzi. It's actually Pierluigi's nephew, Gambetti's nephew, and he's really an expert at interpreting imaging of patients with suspected prion disease. And if you have an image, if anybody has an image, any of our clinicians or whatever, they can send us that on a disc or however you send it. We'll send it to Alberto and you'll get an expert interpretation. As you know, just from working with your radiological college, I mean, you have some radiologists that are better at certain things than other things. And nobody, because of the rarity of disease, nobody's really good at making a diagnosis of Creutzfeldt-Jakob disease on imaging. Because nobody can have that experience except for people like Alberto. So if it's an issue, if it comes up, just offer, say, look, you can send this stuff to the Prion Center and they'll get you an expert read for free. And the turnaround time is pretty darn quick too, I believe. Okay, so this is kind of neat. I don't know if you guys have been there before. If you look at this link at the bottom, this is really kind of a fun website. So it's down at Brown in Rhode Island. And it's a little Bayesian, calculator thingy, right? So what you do is you put in your prior probability, you put in your test sensitivity and specificities, and it gives you this sort of visual about how things will work out for you. So the good news is we've got two pieces of good news and one piece of, pretty bad news that again, I'm, hoping that you all can help us with. The good news is that last time we went through this, when I did the what everybody needs to know the first time, our prior probability was about 5%. So only about 5 in 100 CSFs that we got turned out to really be prion disease. We followed up with autopsy and all that and did all the calculations to figure that out. Now we're doing better. So about 10% now turn out to be prion disease. Now part of that might be because our diagnosing is better in terms of we're picking up more cases, I think, because of the RT-QuIC. At any rate, so now you can do 2 tests. We actually do 3. We do tau, and there's a story there we can talk about if anybody wants to. But really, the one that we like, the one that actually looks for prion, is the RT-QuIC test, and I'll show you that in the next slide if anybody's not familiar with it. The one that all the clinicians know about is 1433, which at a time, very long time ago, wasn't too bad at distinguishing prion disease from other neurodegenerative disease. And that's the key, right? I mean, it's not from just other diseases that can look like prion disease. It was from like Alzheimer's, for instance, right? So the thing is now that if you have, these CSFs that come in, the way it works out is that both of these tests, both RT-QuIC and 1433 are, for all intents and purposes, about 90% sensitive. The difference is that RT-QuIC is almost 100% specific. And again, in this calculator, we have about 99.7, something like that. I could only go to 99, so I couldn't do point whatever. On the other hand, the problem with 1433 is that the specificity kind of sucks. It's about maybe 70%, and so what that means is that you're going to get a lot of false positives. And particularly when you have a prior probability of 10%, what that means is that when 1433 is positive, what you see here is the red dots are people that really have prion disease, and the blue dots are people that are really healthy but have a positive 1433. And so, you hear this all the time. Oh, well, we have this patient, we sent to 1433 and it was positive, and so they have prion disease. And clearly, if you do the numbers there, about 3/4 of the people with 1433 do not have prion disease, right? That's a big mistake, right? I mean, come on. Anyway, with RT-QuIC, what happens is that mostly everybody who's positive, and that's the way we gauge it, right? You can make various cutoffs, and I'll show you the curves, but basically we make it so we have the fewest false positives we can, and actually we have fewer than this. Again, like I said, I couldn't do a 99 point something with this calculator. So you only have a couple of folks in here that are not diseased. And what we'll talk about right near the end is that, it may well be that they may have, it's sort of a situation a little bit like we ran into when we started talking about diffuse plaques a million years ago. Again, most of you are probably too young for that, but we used to have our Alzheimer's diagnosis and neuritic plaques and this density and all that. And then we developed antibodies, and all of a sudden everybody had a brain full of amyloid. Okay, what do we do now? Well, I think we may be somewhat like that because we can basically RT-quick levels that are below the level at which we can transmit disease. So they're below the level of bioassay, but we can still pick them out by RT-quick. Okay, so here's the way RT-quick works. Basically, you take a bit of normal recombinant cellular prion protein. We use a little section of hamster PRP, and you mix that in with your sample. And if there's nothing there, nothing happens. If there is a prion there, you get the autocatalytic templating, and we mix in some thioflavin and we shake it around a little bit. We stick it in out of a fluorescent plate reader, and there will be first nucleation and then elongation. And with the elongation, we get incorporation of the thioflavin and we get a signal, right? So here it's like a positive brain, zips up right away. Tons of prion there, and it's already pretty much nucleated anyway. Here is our negative controls, flat line, flat line, flat line. And here is a positive CSF, a typical, CJD MM1. We'll talk about that in just a moment. And what you see is there's that little lag time, and then there's this sharp increase, a sharp rise when you get the elongation phase. And so with that, we run 4 wells. If 2 are positive, it's positive. And that's what we call it. And again, we want to see that sharp increase, because other stuff, you can get weird, funny stuff going on, but that's not really true positivity. This is for anybody who's old enough to remember, you can't drink it slow, but it's quick. One of the problems with the name is that the assay isn't that quick, although it's getting better. We're changing conditions, the temperatures, the SDS, we're getting to, down to, a couple of days, but it used to take much longer. So here's our first case. A 76-year-old guy, progressive behavioral cognitive visual dysfunction. So I don't know if you guys had gotten the slides ahead of time. I don't know if you had a chance to look at it, but at any rate, we will look at them now. So here we go. This is it. What you see is that we have a section of hippocampus, right? We all recognize that. So let's take a look there. And there's a couple of specific reasons I use the hippocampus here. One's because we all love to look at it, right? But you can see all the neurons lined up here. And if you look down in the hippocampus, you see that, it looks pretty good. Looks normal. You don't see any tangles, Lewy bodies, anything, any funny business, gliosis, anything like that. See a few holes. You see the typical sort of artifactual peri-nuclear clearing and pericapillary clearing. But as you exit the hippocampus proper and move your way over to the subiculum, and then ultimately out to the, drag this out here, out to the neocortex, what you see is that there is spongiform degeneration. And the spongiform degeneration is full thickness, and it's diffuse. It's not patchy. You pretty much see it anywhere you look, and that's important. And the typical, most common, and it's, responsible for about 2/3 of sporadic cases, this so-called MM1, has these very fine, small vacuoles, and they're full thickness. And that's the classic appearance, not this, but that. So again, this is typical hippocampal sparing, full thickness, diffuse, fine, small vacuolization extending throughout the cerebral cortex. And in fact, striatum, and you also see in the cerebellum, and. Because what happens is that typically, and I'm sure many of you have had this experience already, that when you're looking, for instance, at a diffuse Lewy body disease case or some sort of neurodegenerative case, you can see some patchy spongiform stuff. I mean, really spongiform stuff, not fake, not artifact, not edema. It just happens. But if it only happens in a little place, that's not prion disease. Okay, so that is the point there. So now let's go back to our regularly scheduled program, and we will talk about that a little bit. So where do we go here? Where's my guy? There he is. Okay. So these are some of the possibilities of stuff you might see under the scope. And so you basically have to distinguish this first thing here, fixation artifact, where the clearing is really around cells and around blood vessels. You got to make sure you're not looking at ischemic necrosis. And again, I get these, but and not from neuropathologists, but sent in cases like the one we already saw, where it's just the edema related to neuronal degeneration. And luckily, of course, the edema waxes and wanes with the eosinophilium, so you don't have that problem. Status spongiosis is a different beast entirely, right? Where you don't have any, where basically there's no neurons left, or virtually no neurons left. And so you just have this glial scar. Now, that can happen in long duration prion disease. So it doesn't exclude it, but it's not spongiform degeneration. And then finally, what we just looked at, our fine spongiform degeneration. And the way it works is, and you probably know this already, but basically we diagnose prion disease largely by a surrogate marker, which is the migration of the proteasase-resistant prion protein on a Western blot. And again, what I'm trying to do here is really just stick with H&Es and stuff, but and based on the migration, we really get two forms. We get a type 1, which is a little bit bigger. The cleavage point is here around 82. So you get a little bit bigger protein than type 2, which is a little bit smaller. And these really tend to segregate pretty strongly with the codon 129 polymorphism. That is to say that if you are homozygous for methionine, you almost always will have type 1 prion protein, almost all the time. And you very rarely see it if you're homozygous for valine. If you have a valine, either 2 valines or 1 valine in a methionine, you tend to you end up with a protein that digests a little further, and you have type 2 prion protein, which is to say that if we call them MM1, MV looks the same, but MM1, VV2, MV2, these 3 make up 90% of sporadic prion disease. The other things are really pretty rare. And so that's what we're going to look at for our histopathology part of the program. And so, as we already looked at on the virtual slide, classic, the MMMV1 involves all cortical layers, fine spongiform degeneration, and relatively spare at the hippocampus. Here's the 3F4, the immunostaining, which you see is all the way through the cortex. And when you get to the hippocampus, it tends to relatively spare. I mean, again, you can have a little bit of sting, but there's relative hippocampal sparing, which is nice. Because in many of our other neurodegenerative diseases, the hippocampus is quite prominently involved. And so sometimes if you have a status spongiosis case, you get to the hippocampus and it looks pretty good, then you think, well, it could be prion. All right, now the second most common, or way behind, but so that's about 2/3, about 15% or so are VV2, homozygous for valine at codon 129, and the prion protein, which digests a little bit further down, and migrates a little bit further on the Western blot. And so what we see there is when you're looking at the cerebral cortex, it's a little less impressive. Often the spongiform change is right at the gray-white junction. And when you're looking up the superficial layers of the cortex, and we zoomed in on here, it would look pretty normal. So it can look kind of subtle on a cerebral, say, biopsy, if we're going to have a biopsy of this. But other parts of the brain do not look anything but subtle. So this is, for instance, the striatum. And what you see is here is very prominent spongiform degeneration with, again, morphologically preserved looking neurons, so not ischemia. And the cerebellum, this is the ataxic variant. And you see that, the cerebellum often undergoes tremendous amounts of atrophy, and you can appreciate that very readily on H&E. So even though the cortex is pretty subtle, other parts of the brain are not at all subtle. Okay, so this is the VV2, the second most common form of sporadic prion disease. So let's look at another slide now. This is a 58-year-old, a little bit younger, alcohol and drug abuse, and now sort of a longer history, 2 years of dizziness, initiated by motion, although I suppose if you did enough drugs and alcohol, you get that, right? And recent memory difficulties. I mean, all these things that clearly could be alcohol. At any rate, this is just to, I didn't mean to do it. I got to switch over again. And this is just so you guys can see this, because now it's something we sort of see a lot of now, but of course you don't necessarily, depending on if you look at prion cases. So now here's the cerebellum. And remember what we just said about the VV2, how the cerebellum shows tremendous amounts of degeneration and gliosis, and you don't have any Purkinje cells left, and you see a really spongy molecular layer. Here, you see a little bit of sponginess. This is kind of about the level we'd see in a typical MM1 case. But what you see in this case, and again, I don't know if you had a chance to look at these ahead of time, but what you see is these. So these are Kuru plaques right here. So some people like to call them Kuru-like plaques because it's not Kuru, but we just call them Kuru plaques because this is what was seen in about 60% of the Kuru brains that were initially looked at. And it's made up of prion protein. So if you immunostain this, it's prion protein, very distinctive appearance with those sort of, looks like a supernova, all these little spikes, or like what you see in like, not nocardia, the other one, with the complement. But at any rate, it's, you see these extracellular prion plaques. This one has tons, which is why it's here. You don't know, they sometimes are really hard to find. But now you have it in your collection. You'll be able to go back and look at it. And we tend to see these really in the sporadic MV2 cases. It's pretty much defined by this. And they're always seen in the cerebellum, rarely, very rarely outside the cerebellum. And when we see them in the cerebellum, they're really in the they're in the granular layer, not the molecular layer, which is where we tend to see the staining in the type 1 prion protein. So at any rate, we look in the cerebellum for this. The cerebellum often shows mild spongiosis compared to VV2, which is very severe. And again, in the granular layers where we see the Kuru plaques, and almost never anywhere else in the brain, but very rarely, yes. But the Kuru plaques. So it's also been called the Kuru plaque variant of CJD, the MV2. So there's our history again, and there's my guy. Okay, so this is just showing you just both the distribution of the types that we see. So you see this adds up to about 90%, right? Yeah, right. And so about 2/3 MM1, about 15% VV2, and those guys have a very short survival, typically rapidly progression course, whether it starts with cognitive impairment or ataxia. And the MV2s show this so-called heterozygote advantage, presumably because when you're trying to template, if you have these different polymorphisms, it's a little bit more difficult, it's a little bit longer. And so these people tend to live, significantly longer. We saw that definitely with Kuru, these heterozygotes live longer. And so this is a known thing in genetics, heterozygote advantage, and it certainly comes into play here. So people with these somewhat less common forms of sporadic prion disease often have longer duration cases, longer duration histories and duration of disease. Okay, so here it's a biopsy we got actually a number of years ago. A 36-year-old woman, I can't read this because of the little Zoom things here, but anyway, it's a 36-year-old woman had problems, right? Cerebellar dysfunction, then cognitive decline, and supposedly there was a family history of spinocerebellar ataxia. Again, obviously other people in the family had trouble with balance. And so this is what it looked like. So we got this biopsy, some surgery cells and biopsy. And when you look at it, it's spongy, but also there's this kind of multicentric plaque, amyloid eosinophilic junk here. And so basically what we have is spongiform degeneration plus these multicentric plaques, and that's pretty much defining for Gerstmann-Straussler-Schenker syndrome or Gerstmann-Straussler-Schenker disease. And this is showing you the gene for the prion, and that we get gazillions of mutations, except that we really only get about a half dozen that are not rare. Right? And amongst those, the ones you see in green there are ones that give rise to Gerstmann-Straussler-Schenker disease, which again is defined by the presence of these multicentric prion plaques widespread within the brain parenchymal tissue. The most common is P102L, but whatever. So that's what we have in this case. And this is just showing you another area. This is the cortex again, showing you, or it might have been striatum. Yeah, I think striatum. And what we see is the multicentric plaques there. We also see plaques in the cerebellum that look a little bit like Kuru plaques. They look actually a lot like Kuru plaques, but as I said, in the MV2s, we really only see this in the cerebellum. We don't get all this stuff, in the rest of the brain, in the striatum and in the cortex and other regions of the brain like that. So widespread, multicentric, prion immunoreactive amyloid plaques are basically defining for Gerstmann-Straussler-Schenker. There are many mutations that may be responsible for that. And, we sequence obviously all our positive cases to look for that. As it turns out, many of the familial prion diseases, genetically determined prion diseases, show histologies which look exactly like sporadic. So many times you can't tell if it's familial or genetic by looking at it. You really need to sequence, and we do sequence all positive cases. And so here I just wanted to include, just so you had it in your slide deck, a picture of variant CJD. So again, I don't know if there's such a thing as vintage spiritus beef, but at any rate, there you have it. Again, a longer period of cognitive decline. And what we see is these florid plaques. And they're called florid not because they're obvious, but because they're supposed to look like flowers, right? So this is what is the hell is this thing? It's the stamen, right? And then I think they're pistil. I don't remember my parts of a flower, but that's the center. And then you see the vacuolization around it. So these are pretty much restricted really to variant CJD. You can occasionally see something a little bit like it because of, just chance in the very rare cases, say of MV2 with plaques in other places, but you really don't see them in abundance outside of variant CJD, which of course we don't see in the United States, at all. We've had a few cases, all of which have been acquired in other parts of the world. You can see stuff again, looks a little bit like those Florid plaques of MV2, but again, the point is you got to look beyond the cerebellum. You don't get this in MV2. And in the thalamus, we can also see these little sort of supernova looking plaques here. And if we stain for it to be really obvious, but again, most people don't have 3 or 4, you're not going to be doing that. So the idea is to be able to recognize stuff on, as us old farts call it, the good old H&E. Okay, now for our final, we are going to be able to make time, I think. For our final case, we have a younger person who had a longer history, a little bit more complex, anxiety, double vision, trouble with walking, panic attacks that came at night, couldn't get back to sleep, and then developed memory problems, trouble swallowing, and myoclonus. So again, we went from the horses, which is the MM1, to the zebras, which is the VV2, and now we're hitting the unicorns. And this is what we have. So let's go back here and go to our next case. So as I hope anybody, again, I don't know if you have any time, but realize this is the medulla, right? So what we have is 2 hemi medulla, and this would be where the ventricle is. And so this is the ventral medulla here. And so this is the inferior olive. Well, there's one there and one there. It's kind of, flipped over, right? And if you look at that, what you see is that the olive is pretty much devastated. There are like no neurons left. There are a few neurons left on the outside here, right? And the rest of it is completely shot. It's just a glial scar, no neurons at all. And I really like this because, for a couple of reasons. Obviously, one is that it's small, so you can look at, I always, prefer locus coeruleus suspension nigrate, get stuff done more quickly, right? And so here you can really look at the whole thing and you can see the massive gliosis, the complete loss of neurons. And this would also be true, presumably in the thalamus in this case. Actually, it wasn't presumably, it was in the thalamus in this case. And we know the thalamus, of course, is the epicenter of fatal insomnia. But why do I like the olive so much? Well, how many times have you seen gliosis in the thalamus? I mean, it's not uncommon, right? With ischemia, metabolic diseases, with degenerative diseases. But, how often do you see a completely gliotic olive? Like never, right? I mean, unless there's something else that's there, like some kind of brainstem stroke or, cerebellar tumor or, something that interferes with the central tegmental tract or something like that. So really seeing a gliotic olive like this is pretty, is very useful, I think, in considering the diagnosis of fatal insomnia. And that's important because in fatal insomnia, often, depending on again, the polymorphism, and that sort of determines the duration of disease, the cerebral cortex can look entirely normal. And in fact, if these people undergo biopsy, the biopsy will be normal. There won't be any prion-resistant protein there, at least early on. And so you really can get, a false negative biopsy, which is not very helpful. But so you have to be aware of this. So we now put in a disclaimer that, if fatal insomnia is in the differential diagnosis, that you got to do something else. They got to do some polysomnography, or you can do FDG PET and, see the decreased uptake in the thalamus. There are things one can do, but pathology is not one of them. At least biopsy pathology. So I think it's good to be aware of that. So as Dr. Eastwood had once said in the movie, a physician's got to know his limitation. And so one of the things is that, first of all, you may not have insomnia and fatal insomnia. It's not really defining. There is, sleep difficulties, but they, they may not be, quite insomnia, so to speak. The usual things we look for, the MRI, the EEG can be normal. RT quick's often negative. In fact, that's almost a feature, and it's a feature of some of these other rare prion diseases as well. So a negative RT quick, just like a negative anything, doesn't exclude whatever it is you're looking for, right? Negative JC virus PCR doesn't exclude PML, right? So same thing with this. Now, and again, what we're trying to do is we're trying to minimize the false positives. We're letting a few get through. And in fact, again, what we often find is that in these patients with the RT quick negativity, sometimes they have a super high tau protein, so that's one reason we run tau at the same time. That'll sometimes give us a clue about that. Brain biopsy will be negative, autopsy can be negative. That's why sometimes if you guys have sent some slides in, let's say, oh, I want to send let me just check before I cut this brain. If you send us, just a piece of cortex and cerebellum, which is nice, and they're negative, you're going to get back something to say, well, they're negative, but, we can't be sure it's not fatal insomnia. So, the ideal thing is send us a little bit of cortex, send us a little bit of cerebellum, and send us, medulla, thalamus. So again, there are other things you can do. So the PRP, the immunohistochemistry, interestingly enough, is usually negative in the thalamus and the medulla, but it can be positive sometimes in the entorhinal cortex. I'm not exactly sure why. And then when we have the whole brain, usually by the time of autopsy, we can pick up a Western blot positivity, particularly if we do some enhancement concentration techniques on the CSF, on the brain. So. Okay, so now the final few minutes of what would have been the first hour, what happens, when something bad happens, when everybody's panicking that, oh my God, we ran this specimen and, or we did this surgery and. So first of all, we haven't seen, unlike, syphilis, which I'm told you can pick up from toilet seats and other STDs, we haven't seen any prion disease picked up from surfaces. So far it just hasn't happened. There's also no increased incidence of prion disease in healthcare workers and that sort of thing. So epidemiologically, it hasn't been a thing, right? But people don't like that. They say, look, that doesn't mean it's not going to happen to me, right? I'm panicking. I can't sleep anymore. I'm a wreck. So, well, what else? Give us, let's talk about this a little bit more. So we will. Now, this is really. I've always been a huge fan of Dr. Cerebellum, Mike Miller's old mentor, if he's here, his stuff, which is that, we do know that nucleic acids are not a part of this, right? That was the thing at the beginning. Oh yeah, there's got to be some small nucleic acid there somewhere, can't just be a protein mediated disease. It is. And we, we've also known that for longer now than the time we knew about DNA being responsible for disease and viruses. Before we learned about prion. So it's been a thing for forever now. So we know that. But one thing we also have learned is that naked prion protein doesn't work. It doesn't cause disease. It needs stuff, a little bit like probably like the ApoE story and Alzheimer's and stuff, but that you need to have other materials there, other ground substance like glycans and all that to cause disease. So if you get naked protein only, you can't cause disease in humanized mice. You just can't do it. You got to have other stuff. That's why, for instance, if one does PMCA, which is where you actually amplify, instead of using recombinant substrate, you use actually brain homogenate. Those reaction products are infectious, but RT quick reaction products are not. So again, you can't, you need to have more than just protein, even though, again, if you get rid of the protein, you get rid of the infectivity. So it is, protein mediated disease. Okay, so again, you hear from your lab tech, look, I don't care to end the report. It's not good enough. I need another reason. Say, okay. So here's a article is written just 2020, middle of 2020. And that was doing exactly that. We did the assays that one does to assess infectivity using CJD CSF samples. There is infectivity there, but just taking samples, a bunch of samples that we did the standard infection bioassay. And basically, we got no prion disease in any of these animals. So these are humanized mice. Basically they're made to be like human brains. And so we got none of that, no neuropathology, and no RT-QuIC. So it really looks like CSF, just doesn't transmit disease, and particularly not in this in a casual situation where you ran samples in a lab and now they can't use the machine anymore. Some stuff like that. Well, what about let's up the ante a little bit and let's take these RT-QuIC products. And now we amplify these patients with prion disease with RT-QuIC, and now let's take the resultant stuff, stuff that we see in fluorescence, showing us that that stuff's there, and let's inject that into these humanized mice and see what we get. So so we do that, and what we see is no clinical prion disease in these the standard bioassay mice. In addition to that, their survival time is normal. So again, there is some funny stuff you see, but it's not typical prion disease, So again, there's a little disclaimer there, but again, no clinical disease, and the pathology is very atypical. You see in some of these mice. I don't know how to do with thioflare. I don't know what it's from, but it's not at all what you see in the controls, which is basically taking the brains of these patients and sticking them in the mice. That's the positive control. Doesn't look anything like that. But it's funny. We can go back in there and we can amplify out of humor. And so what we are learning, and what we know now actually, is that RT-QuIC is more sensitive than bioassay, which means that we can, number one, detect much more sensitively than bioassay, the presence of, autocatalytic prion proteins. What it does bring up the question of is that, are those infectious or not? Depending on the level, it seems to be below the level of infectivity. So it may well be, for instance, those few false positives that we get in the RT-QuIC in the lab actually have prions in the brain, but they're not at the level where they can cause disease yet. Interesting question, I guess. But importantly, no clinical prion disease either from CSF or from RT-QuIC amplification products, which might be like, you could say, well, okay, that could be kind of like if we had processed some blocks, of a prion disease case in our machine, and they got washed around, and one can't imagine that you get more than what you would get with an RT-QuIC experiment in those sort of solutions and stuff. So again, I really think that you shouldn't panic. But if it comes up, this is the place I think that you get the best information. And this is the website over in Great Britain, for the variant, they really jumped all over this place. So this is the UK government publications guidance from the, basically the risk management group here, formerly the TSA working group. And I'm quite proud of myself. I never did before, but you can actually do right now, you can hold your phones up right against here, and you can read this, what is it, QR code, QRQT, whatever it is. And it'll take you right to the site. You'll see there's a whole bunch of these white papers and guidelines and everything, having to do with spills or containment or, relative, you name it, it's there. So at any rate, if there's ever any question, just get the presentation out, hold your phone up to here, and then you're good to go. So now at exactly what would have been 1 o'clock or 12, 11, 10, depending on where you are, we're at the end. And this is supposed to be where I say Q&A, but I always think it's helpful rather than just say Q&A, is to say, look, what we're trying to do here. So now you can take a look at this and say, well, did I get all this? So have we figured out how to help our clinical colleagues with their imaging and with their interpretation of cerebrospinal fluid studies? I hope so. Are we somewhat familiar with the spectrum of prion disease in terms of, what do we see most of the time? What do we see occasionally? What do we almost never see? And therefore, what we have to be particularly careful about if we're considering very unusual types of prion disease. And then finally, what do we do when something bad happens or apparently bad happens? And I think now, I think we've covered all those things, but if not, feel free to ask. And, I can stay a while, and, I know we're over what would have been time, but we started late. So I'll turn it over to, I don't know what I do.
Yes. Yes. Well, no, thank you. That was awesome. That was a great talk. So we'll move into Q&A. You can submit your questions via the chat box or unmute to ask a question. When submitting a question via the chat, please ensure the message is to everyone so that the presenters and attendees are able to see the question. To unmute, select the microphone in the lower left corner, and once you've asked your question, please remute to avoid background noise.
And also, if you want, I can give you my PayPal account. You could like just deposit $20 each time you ask.
Sure.
Any questions?
Yeah, I'm just going to send a message to make sure the chat box is back on. 1 second.
Yep, the chat is on.
Okay.
And it looks like we had a couple questions earlier in the session before I got that disabled.
Yeah. So I will read the one question. So there's a question, let me back up a bit. There's a question from Dr. Howard Chang. Are all tissue blocks for histology and immunohistochemistry treated with concentrated formic acid? How long after formalin fixation, ?
Yeah, so they are, just long enough. I mean, just as long as you fix anything in formalin. So, overnight, or it depends how big the pieces are and stuff. So, but yeah, just regular form of fixation. Then we, put in formic acid for a few hours, and then you put it back in formalin just to, get the formic acid out, and then you process it. And you could, at that point, you could eat it, I suppose, and you wouldn't get prion disease, although you might get sick.
Are those protocols on the UK website?
Yeah, and I think they're on ours as well, but they should, I think they're there. Yeah. Yeah, they're there. They're there.
Okay. And then I'm not sure who it's from. It says, we see lots of vacuoles in neurodegenerative diseases that look very similar. Any suggestion?
Yeah, well, again, it's really the distribution, so again, usually in neurodegenerative diseases, you might see some focal medial temporal lobe vacuolization, or, if it's I don't know, Huntington's or something, it might be in the basal ganglia. But the thing about prion disease is just like the clinical criteria used to be before we had RT-QuIC, and now we have RT-QuIC. So the WHO now says, well, look, anything funny going on plus RT-QuIC equals prion. But used to be that you had to show that you had involvement in multiple systems. It couldn't just be rapidly progressive dementia. You have to have like dementia and ataxia, or ataxia and spasticity, or so same thing with the vacuoles. You really want to see them in multiple systems. You want to see them in the cortex, basal ganglia. Sometimes you see them in the midbrain tegmentum and tectum. I mean, so it's really widespread, diffuse, not patchy, here and there.
Okay.
Does that help?
Okay. Then I have a question, but if anyone of the participants would like to unmute or ask a question, I don't want to co-opt the questions.
Yeah, let me go one thing though. Since you mentioned the formic acid, now one thing I try to do when people say, look, we got a biopsy, want to send it to you, and stuff like that. What the best thing to do is to send some of it and keep some of it, because what happens is what we do is we take everything we get here, assume it's positive, put it in formic acid, and that, thus such. So that means that if it turns out that it's, well, something where you need to look at DNA, something like lymphoma or viral infection, that's all destroyed in the formic acid treatment. So it's always good to keep some not treated, if you're going to send stuff here.
Okay.
Anyway,
Okay. I think I'm going to go ahead and ask my question. You discussed the heterozygote advantage, and you said that these people live longer, but I was unclear. Do they live longer with disease, without disease? And like in this context, I'm not sure I understand what you mean by heterozygote.
Right. No, they live longer with disease. So, one can argue about what is that really an advantage? But at any rate, they just have a longer duration of disease. We don't know. Again, we have no idea why somebody develops prion disease. We also don't know exactly why people with genetic prion disease are normal for many decades, before they, develop disease, So basically it's the duration of disease from, disease onset that's longer with the heterozygotes. So we always think of, rapidly progressive dementia, people should be going downhill almost daily, almost weekly. And sometimes we see these people with 2-year histories and we say, well, that can't be prion, but it can, the MV2s are typically like that.
Okay. And then I have a question from Dr. Abdulkar. I can't see the name very well.
I see it there. Can we find prion disease in brain biopsies or resections? And the answer is yes, we can. We do. But again, the reason to look it's not because you want to make a diagnosis of prion disease. It's because you want to exclude a treatable disease. Otherwise, there's no reason to do a biopsy, right? So we can do that. It turns out now CSF RT quick is as good, I would think, as a brain biopsy at this point, because sometimes you don't. Again, as we talked about in our unicorn case, we will not find it even in a patient that has prion disease, fatal insomnia. The other thing you got to remember when it comes to biopsies, and this is something I talked about in the whatever neuropathologist needs to know, is that prion diseases only affect gray matter, right? So if you get, a lot of times people are getting biopsies, they're shooting for white matter stuff. And so if you send white matter, we can't say anything about that. The absence of prion and white matter doesn't mean the patient doesn't have prion disease. It just means that, as we all know, you don't have prions and white matter. Similarly, when we have a wall-to-wall glioblastoma, and somebody says, well, you know what, we'd like to know if the patient also has prion. We can't do that. I mean, it doesn't work. You got to have just great, you have to have some neurons and synapses and neuropil and things like that. So yes, a cortical biopsy, we can find prion disease most of the time, not in fatal insomnia, but most of the time. But again, we usually don't look because, usually, well, it depends. It depends on the place where it's done. I mean, in many places where there's neuropathologists, they just take care of it. But again, if you're going to send us a biopsy because you're concerned about prion disease and you don't want to run it through your machines, keep some, for when we say negative.
Okay, and then I have another question. I read that there were a lot of cases of some type of neurodegenerative disease, mostly in New Brunswick, Canada. Did you look at any of those cases? Do you have anything to say about what happened up there or what's going on up there?
Yeah, well, this one where I know somebody who knows somebody who knows somebody, and apparently it's not prion. So that's what I've been told by people who I respect, So
Okay.
I myself, but it sounds like that's not.
Okay, and then I'm still not seeing other questions. Can you tell me, how do you explain to a medical student what RT quick is?
Well, okay, so this is a joke I've riffed on many times before. I mean, so where'd you get this name from? So, but anyway, let's go from the bottom up. So, what we know, what defines prion diseases in some sense, well, it's three things really. So the strains, autocatalytic templating, and transmissibility. But autocatalytic templating is the fact where you have an abnormal protein, and what that protein can do is if you mix it with normal protein, it will convert that to an abnormal conformation. So what that means is what you can do with prion protein is essentially analogous to doing PCR. What you can use is you can use it as a template by which you can amplify an unknown quantity to see if there is something you're looking for there. And so so RT quick, what we do is we look for the presence of abnormal protein by adding an excess of normal protein and see if that abnormal protein will repeatedly convert. So we do like PCR. PCR, you heat it up, low it down. So with RT quick, what we do is we shake it and we let it incubate. We shake it some more to break the piece apart and let it incubate. And that's what it is. So why is it called RT quick? Well, if you think about it, what are you doing? You're shaking this mixture, and by shaking it, you're causing normal proteins to transform into an abnormal conformation, which is capable of being responsible for disease. The problem is, if you think of what the abbreviation would be for that, it'd be real-time shaking-induced transformation, you can see why maybe they decided to use some other words.
Okay. And then what's the turnaround time on the machine?
Well, I forgot what we give now. I think, I'm not sure we say it'll take about a week or so, but it probably, from the time we load it, it takes about 2 days, 2.5 days. So we got to prepare, got to put it all together, and so. Okay.
And then there's 2 more new questions. I'm thinking maybe we'll do those 2 questions and then call it a day. Can you see them?
I can see the one. Here we go. Oh, do you ever see other proteins co-localizing with prion plaques? Can this be a pitfall? Well, yeah, absolutely. The thing is that, again, if you did immunos, and that's why we didn't spend much time on immunos, yeah, we see, in fact, it makes it really easy to see if you have Alzheimer's disease because there's cross-reactivity. And, but it's weak, and it looks like senile plaques and all that. So yes, you have cross-reactivity, but once you've seen it, you say, oh yeah, that's obviously beta amyloid plaques, and you can then go and stain that too if you want. But yeah, there are other proteins that localize. But again, it's not really a pitfall once you've seen it and you know what it looks like. So, and then the final question, if I scroll down here, if clinicians say we're not suspicious of prion disease at all, can we ignore the vacuoles and histology? Well, no, I mean, so, artifacts, so go back, we could go, we're not going to do that, we can go back. But if you take a look at the slide that had the 4 different histologies, artifactual fixation artifact is, generally shows a pattern where you see the vacuoles are much more prominent around cell bodies, cell nuclei, and around blood vessels, and not so much in the neuropil between those. So you should be able to tell artifact from true spongiform degeneration without clinical input. And just go back to that slide and check it out.
Okay. Okay, well, the AOE host should be reading something, but I'm going to read it for them because I'm not sure they have access. So thank you for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Hopefully someone will put it in the chat, otherwise you won't be able to do that.
Dr. Oviedo.
Oh, yeah.
I can jump in here.
Oh, good.
Yes, I'll reiterate. Thank you so much for joining today's teaching rounds, and thank you so much, Dr. Cohen. And thank you all for your patience with our blue sky snafu with our LMS. So we will be reaching out to all registrants to talk about evaluation for this particular activity. So please keep an eye out. If you don't hear from us within the week, please email me directly or the AANP email directly, and we'll make sure that you get set up with that. But thank you all again. Dr. Cohen, thank you for an excellent presentation, and this does conclude the session for today.
All right, see y'all.
Bye, everybody.